Yeah. You know, it's funny that the Access talk is, after we've had such great technical talks on, you know, all the latest and greatest evidence, what's coming out, new innovations, but it is incredibly important and relevant. And I can say that Access, though it's the beginning of what we do for any case, can make or break your whole day, your whole case, and is one of the biggest complications still that we deal with. So it's important, it is relevant. We're going to be talking about why Access is relevant. We'll talk about the current femoral access rules. We'll talk about how closure in the modern day, God, in 2019, it's a must. It was probably a must in 2010. And alternative access in the 21st century. And so, you know, the reason it's been rediscovered as to why we do arterial access has really been, again, the revolution of need for large vessel access in the past couple of decades. That started with transcatheter valves, and I'm going to focus more on the arterial side, but remember, what I'm talking about is apropos to anything on the venous side from the size of the sheets. Large bore stents, such as TVARs and EVARs and coarctation stents, which a lot are familiar with. You have all sorts of different valve systems that are now approved, and TVAR, EVAR stents, but remember that while the valve systems have gone down in size to 14 to 16 French from the arterial side, you still have TVAR. By TVAR, I mean the self-expanding aortic stents for aneurysms, which can be used for coarcts as well, that go up to as high as 26 French. So having strategies to deal with large access percutaneously is an issue. The second issue why we've had to rediscover access is because, you know, our patient population in the adult side, we're doing higher risk patients, patients with more comorbidities, and more elderly. I know the focus is on S3, low risk trial, and partners, and how you know, we can do lower risk patients, but certainly still the majority of patients in the structural world are relatively high risk, and you still get the occasional 101-year-old coming through the door, and they often have other issues that get into place. Finally, I think there's been a lot of interest in back to access for all interventional cardiologists, structural or otherwise, because of the increasing use of mechanical support. And that's in pediatrics and in the adult side, but you've got different support systems, such as the Impella, ECMO we heard about. You know, in our lab, we actually put in the cannulas to start with for ECMO as the surgical team is coming in, and so it's important to be able to manage the large kind of systems that are in place. And at least from the percutaneous side, when you're looking at Impella CP or you're looking at Impella 5, you're talking in general for the percutaneous solutions anywhere between 14 to 17 French. Okay. Why is access an issue? Well, let's be clear, bleeding is related to mortality. We know that. We know that from the TAVR literature. We know that from the PCI coronary disease literature, that bleeding, though we used to think it wasn't a big deal, even in smaller French sizes, bleeding is linked to mortality, and certainly in larger access situations, and thus preventing bleeding in addition to the dissections and the thrombosis and the various procedures and interventions that come up if there's complications is incredibly important. This analysis from JACC Interventions a few years back now, it did show that, again, life-threatening bleeding, higher risk of death, major bleeding, high risk of death. What might surprise you is even minor bleeding, higher risk of death. So how to manage that in this population. One issue that has occurred in the last 5 years, if you had given this talk 5 years ago in the US, 95% of adult interventional operators did femoral first. And in other places of the world, they were doing a lot more radial artery access. That percentage in the US has shifted now, so it's almost on the order of 35%. And so in our particular lab, we're about 60%, 70% radial at this point for anything that's non-structural. Obviously, you're not going to put anything more than a sheathless 7 or 8 French guide at the most to the radial artery. But what is that doing from a training perspective for our fellows is that they're getting a lot less femoral experience. And that's theoretically a problem. We call it the Kapu radial paradox. And if you're performing the procedure less frequently, are you going to have more problems when the time comes to put in an Impella or to do an aortic valve replacement or a TAVR in a team? The data is mixed on that, but there is a concern, and we see it in our fellows where they're later on in their interventional year, they're still at the stages where we saw fellows maybe a decade ago, when it was primarily done through femoral artery. So the technique for femoral access, this is, this talk, you could in some ways is going to be circa 2010. I'm going to give you, because a lot of the data that supports these basics of how to get appropriate femoral access have been around for a while. And I'm sure everyone in this room, in this austere room, knows these important things. Getting fluoroscopic landmarks, making sure you take an x-ray with a hemostat at the beginning to know where the femoral head is. Don't rely on the crease, the femoral crease, which can often be misleading. The older the patient in general, the more misleading the femoral crease will be. That's a pretty, and when you have obesity, morbid obesity, and pannus, it can be even more challenging from that perspective. It is important to get fluoroscopic landmarks. Obviously, we're trying to go at the point, the mid-level of the femoral head to allow compressibility in case when the sheath comes out. The lower you go, you have a certain sequence of complications. Higher, you worry about retroperitoneal bleed. Why do we try to do that? Well, when you look, when is the bifurcation of the SFA and the profunda actually below the femoral head? About 55% of the time. But that does leave about 20% of the time where actually the bifurcation is going to be above the mid-level femoral head. So which makes you think that just fluoroscopy alone, that's 20% of patients approximately that you're going to get into the bifurcation into a smaller caliber artery. And when you're talking 14 to 24 French sheaths, that's a higher risk, again, of complications. With low, again, I'm preaching to the choir, low sticks, increased risk for AV fistula, for pseudoaneurysms, high sticks, retroperitoneal hematomas. Ultrasound. So just a show of hands, who here uses ultrasound for access? Wow. Okay, this is an incredibly, excellently impressive audience, because I'd say, who is adult and uses ultrasound for access?
Not for a diagnostic, but
yeah.
Anytime we're doing something therapeutic with a large access.
With a large access, always. Okay, and I think there's not just, it doesn't just feel right, there's some data to support that as well. With ultrasound, you can really get a great sense of the artery and the vein location. You can scan down to see where the bifurcation is, not just relying on the fluoroscopic markers. You can also help you point out where there's evidence of calcium, where to stick, where not to stick, doing it under real time. Yes, it is an extra step. Yes, it is a few minutes, but for that one case of calcification where your perclose doesn't hold, leading to a dissection, leading to an intervention, if you can prevent that with doing ultrasound on every large bore case, why not, right? I mean, and so what supports that? Well, there was a study done of about 1,000 patients called the FAUST trial. It's an interesting name, FAUST trial. And it didn't show, the main difference that it showed was it showed a decrease using ultrasound, had a decrease in number of attempts to get femoral artery access. First pass success rates were higher. The risk of puncturing the vein and then going to the artery was better. And the time to sheath insertion was higher. But also, just more importantly, the risk of major hematomas of greater than 5 centimeters was higher. And these were not large bore accesses. Now, put these into the large bore section, and you're going to get a lot more complication rates, most likely. What is actually happening? This is a survey of interventionalists in 2017. In what are people, it's funny that the majority of the room raised their hand for ultrasound. That's fantastic. When you look at actually the percentages, not many are using ultrasound right now. It's the majority are still using palpation. There's a small percentage that are using fluoroscopy, but depending on the location. And ultrasound is only, even in North America, is really only 36% using both. So despite 90% in this room, that's not what's going on throughout the labs in the land. Oh. Okay. Micropuncture access. Who here uses micropuncture needles for femoral artery access? Who uses it always? Okay. So while we don't use ultrasound always, we actually use micropuncture for every femoral access now, everything. And I'll be honest, the data for using micropuncture in adults is mixed. There's not great support for it, but I will say anecdotally, in the 2 years that we've been doing it, in the majority of the time, it's our fellows who are getting access for the cases, whether they're small bore, 5 French diagnostics when we do femorals, or even coming for some of the structural procedures. but it has made a huge difference in the amount of complications because, you know, if you put in a 4 French catheter, we don't even put in the catheter. What we'll do is we'll get micropuncture access. We'll have, if it's going to be a TAVR or something like, we'll have ultrasound of the location, and we won't even put in the whole catheter. We'll just put in the dilator and take angiography. That's basically the equivalent of putting in a 24 French IV into the artery, where if you're in the wrong place, you take it out and you start all over again. And you don't have to hold pressure for very long because it's a tiny stick. It's the equivalent stick externally of an 18 gauge needle. But it's incredibly important to do. What's the data for it? Well, there was a trial that was actually stopped early called a Femoris trial that looked at 18 gauge versus 21 gauge micropuncture. There was really no difference in the primary endpoint, but they had withdrawal of funding. There did seem to be a benefit in women and patients with low BMI. There was, I'm going to tell you the caveat, there's a second cohort study that looked at the same question and didn't find an increased risk of retroperitoneal bleed. So when I talk to some of my more experienced older colleagues who talk about using micropuncture, they always mention that, yeah, well, it's only good is if you actually fluoro the wire once it's going in. Otherwise, that wire is so thin, it can go into small branches, and if you don't look at those branches, that's where the bleeding complications occur. And that's a really important point, that when if you choose to use micropuncture, definitely always do fluoroscopy. Yeah.
But like, a 400 patient randomized trial ends up with such crap journals, like why?
It wasn't completed. Basically it was company funded, and the funding was lost, and so it was a non-significant, didn't meet its power calculations, and that sort of way. Yeah. Okay, last thing is femoral angiography, and who here does femoral angiography after every femoral access? Really? Not everyone? Okay. So that's fair enough, fair enough. Okay, how about anybody over the age of 14 who routinely does femoral angiography?
Interventionist or patient?
Yes, the patient. Thank you for that really austere comment, sir. You know, we do it at the beginning of the case.
Why?
It's, you know, because if there's a problem, if you're, you know, hypotension, you're not going to, it doesn't matter if you're not going to close. You want to know if there's a problem. And so I think whether there's a microdissection, whether, you know, there's somebody who might get a PCI who is, you have a dissection or you have a slight bleed, then you won't give them heparin that day. It's important to know, I think.
What's your yield on that? Do you know the yield?
I don't.
You do that for every diagnostic case?
Every case. That's our routine. That's the routine at Columbia NY on the adult side too. It's the routine at Cornell and Columbia, both places for the adult side, for any femoral access that's happening.
Can I just ask you a question? By the way, is there a reimbursement while doing that in the U.S.?
No, zero.
No, that's not true.
For femoral artery picture, no. We've not for. And you bill for it. We don't bill for it. Yeah. So, what I was mentioning. So this is a case of somebody who we needed bilateral femoral artery access on. I was mentioning that we use the dilator for our micropuncture. No, it's okay. It's access talk. It's not a big deal. You know, and so we use the dilator. It's incredibly small, but you can get position. We had already used ultrasound to figure out the location. And in this particular case, you know, we knew that this was for a coarctation patient that we needed to get to where it's sized out for any of the covered CP stents. So we knew a priori we were going to be using a TVAR stent. But essentially, you know, it's really important to get the right access to minimize the complications when you're going 22 French in this type of situation. Okay, pre-closing. I think, personally, pre-closing should be routine for any large bore access. You can argue and say, well, you know, we've got fellows, they do a great job with the 14 French sheets, and maybe they do. But I think, in general, there's growing understanding that when we're talking about large vessel arterial access, I'm not talking about the routine diagnostics 5 to 7 French, there's a benefit to having closure. Now, as far as which device, does anybody here still use the ProStar? Anybody? Good. It shouldn't be used. I mean, there's increasing data between the control trial. Bravo 3 was presented at SCAI, which showed that really ProStar has increased complication rates compared to 2 ProGlide per closed sutures. And at this point, you know, I think it's pretty much a gone conclusion. And 2 sutures for generally anything more than 12 French in the arterial side is what is recommended from that perspective. So we don't use ProStar much. So once you've gotten to this point, you've done all the different steps necessary to set yourself up for success. So at this stage, what do you want to do? You want to get a stiff wire up through a catheter. You want to do stepwise arterial dilation to get to the size you need while visualizing the aortoiliac segments. You want to look at your pre-procedure CT. That may be something that's not done in every intervention, but the majority of TAVR patients are getting pre-procedure CAT scans to measure, because they often have peripheral arterial disease, to understand, be ready for problem areas. And there are times that we call in our vascular interventionalists to help us for angioplasties or even pre-stenting in patients, not usually stenting, but sometimes if angioplasty to get a valve through. I will mention something that we haven't used yet, but I wonder, has anyone used the shockwave peripheral intravascular lithotripsy? Anybody here in the room? You've used it in coronaries, okay. So we haven't used it in either at this point, but I can tell you that there was a publication just this last month from European experience of 4 centers that suggested that it can be very beneficial in taking care of some of the calcium in the CFA and iliacs. It's sort of a balloon that has an ultrasound signal, the equivalent of what's used to dissolve gallstones externally with kind of focal ultrasound, and it's being tested in the coronaries as we speak in a trial basis. It has already been tested in popliteal and SFA, peripheral arterial disease, and found to be beneficial. But it might be beneficial in increasing our yield for when we can do transfemoral access as opposed to other alternative options. Okay, how do we remove sheaths after we get 14 French or above? Well, manual pressure, good old, time-tested, everybody does it. Can always do that, and it's always considered a part of it. Sandbags and pressure dressings, come on. I mean, are you freaking kidding? C-clamp, I only kept this here and kept the picture because I don't know if we still do that at TGH, but I know we used to do a lot of C-clamps, and if we do, then it's fine. Otherwise, are you freaking kidding? Okay. Fem stop, only in case of emergency, but definitely if you don't have it, you should have it, and it's very, very, very useful, but it is still there. And closure devices, and I've said it several times already, but pre-close should be standard. So why do people often say they don't want to per-close? Well, my fellow's really strong. He does a great job. He'll hold for 2 hours, no problems. You know what the fellow's doing to you behind the scenes, right? Because that sucks, right? And there's been times where I've had a shock patient coming in, like, there's no time. I'm just putting up the impella. And then I think I'm going to, and then the next day when they're holding pressure, they're swearing at me behind their breath. I wish I had, and there's always a hematoma, and I always wish I had taken the extra 5 minutes to do the double per close, even if their blood pressure was 50s, because I think, honestly, bleeding causes complications. I think it's incredibly important, including mortality. So,
Can I ask you a question about that?
yeah, about the gorilla? Yeah.
Yeah, that was really self-explanatory.
Okay.
The case you just gave as an example, the impella going up, who pre-closes
And leaves the sutures.
leaves the sutures for a prolonged period of time when you're not going to come back to the any issues related to that?
We have been more and more. I can't tell you, I don't know of any evidence to support. The question is always about infectious risk, about leaving sutures exposed outside of the body. But I'll be honest, we've seen more complications with the manual pull later. For any impella, and this is usually not so much for this relevance, but we're thinking more in cardiogenic shock patients, either ischemic or non-ischemic coming in. We've been leaving a double per-close suture exposed to the body, given them 24 hours of antibiotics, put on the CG, the special tegaderms to protect it, and then when an impella comes out, you just deploy the suture, you're done. We have not seen infections, and the N is not huge, maybe 30, 40 over the last couple of years, but I think it's definitely, we have not seen any problems. How about anybody else in the room?
I have not personally endorsed that strategy.
Yeah. There's a lot of debate about
Is
it.
there any data about that?
I couldn't find anything on it.
Yeah.
No. And, maybe...
Because it's a big issue, right? Because I think that's the role of Manta, right? I mean, or I don't even know. Once it's contaminated, it's contaminated. You know
Yeah,
what I mean?
yeah.
I mean, I've had to do it, not on purpose, after a PCI, patients
I mean, you could cut the sutures and leave the impella in. There's nothing keeping the sutures in.
So
But
my preference is to do that.
I see.
It's like if you have somebody you can't take it out of the end of the cage, just cut the sutures and that's you have the max.
You know, we've actually done it a few times now, I was mentioning it on ECMO patients. And patients are incredibly sick on ECMO where it's also held. And so I also wonder, and that's usually, that's prevented the whole going back in and doing another cut down, reestablishing closure. I mean, from a surgical perspective, they have found it wonderful. Now, I'm a little bit uncomfortable because they go to the CTICU and we do that, and it's sort of a black box there. No offense, I don't really know what happens, but I mean, I do think that it's doable. You're right, but once you get past the 3-4 day mark, I mean, there's a little bit of risk. Depends how sick the patient is. Okay. Oh yeah, no, it works. It totally works. It works actually that sometimes there's no bleeding around it, right? I mean, it works to that level.
But it's like being a permanent device, there's a real risk of infection. I mean, some operators will leave glove before they re-sterilize everything before they put a fixed close. So I think there's
And you're absolutely right, and that's the reason not to do it. I'm not advocating it. There's no evidence and support for it other than, all I'm saying is that you should pre-close your routine large bore arterial access. But the question was, do you keep it in? Yeah, for our shock patients with impellas, we have been keeping it in, or occasionally, rarely even ECMO.
So for the ones that you pre-close, it pulls out, it doesn't work, what's the largest sheath that pulls that you can still catch it afterwards? I thought that over
I mean, my
You
patients 10 to 14 for a sheet, pull one through,
that,
water, and put another one afterwards.
but that's if you had a 14 French that you had nothing, you had no pre-close, you got a per-close in?
We tended to use one in our young
Okay.
population, not calcified arteries, it tends to work. So, of course, if one's then pulled through, then you've got.
I think it depends a lot on the quality of the artery,
Yeah.
the size of the hole, and the length of the dwell.
I-
So the
yeah.
longer the dwell, the bigger the hole, the less likely to be successful, right?
I agree. I wouldn't count on that. I mean, I think anything above, honestly, 9 French for the most part, you're going to have plus minus whether it's going to catch after you've gone in. I mean, that's sort of the IFU type of thing for 8 French. But but certainly when we're doing double per close and we see a patient who has, you don't have complete hemostasis, if you've gotten partial capture of one of the, then you can keep adding more per closes to get more closure.
I would just say also, to be honest, like, in many patients, one per close is enough for 20 minutes. But the thing is, if you have a failure
I know.
of one,
That's it.
like, the second one is really insurance,
Backup.
right? I mean, like, just in case, because if you have failure on a 20 French, like, it's, your day's kind of no good, right? So,
For a BAV, using like a 10, 11 French sheath, okay. I mean, one per close, and if it fails, no big deal. The fellow is a gorilla, he'll take care of it. But if otherwise, yeah, it's worth doing 2 just to be safe. So this particular patient this is about femoral access. We don't do crossover technique much anymore since TAVR sheath size has gotten really much smaller. But in this particular patient who had a 24 French sheath, we did do a crossover balloon, and actually we had some issues of bleeding kind of right around the site where the perclose was, and you can see that staining there. But luckily the balloon stayed up for about 15 minutes. We just held manual pressure, the balloon came down and the bleeding went away, and so it was a relatively, that technique is still incredibly useful to help manage situations. I'm going to mention the Manta. I have not used the Manta. This is the promo video. I'm sorry to show this in a meeting, but I don't, has anyone used the Manta? Clearly, this is an exciting new device. It's basically an angioceal that you can put in after the fact, up to, I think, 22, 23 French, if I'm not mistaken. And it looks essentially just like an angioceal. It does leave a little metallic anchor plate behind that you can see on fluoroscopy. I guess that's important to remember. So if you're going to re-access that site, you have to go above or below it. But I think it's, again, it's 30 days that you can't access it again, is the same rule as for angios. It's longer than that? I think it's, you said it's 3 weeks. 3 months. Okay. But the IDE trial seemed relatively positive. Their complication rates were, well, the technical success, there you go. It's 97.7% with 5% complication rate. This is easy. This is a great presentation. I'm just going to show you videos of the companies, but it was approved, and it's interesting that nobody has really used it. But okay, we've been, yeah.
Just one other thing. There are a bunch of other people who are doing large access site with one foot closed and then adding an angioseal.
Yes.
That kind of hybrid thing to
Yes.
avoid
Cinching.
cinching it.
We have actually. We've done it before. Some of our senior guys really like to do that. I'm not sure what the advantage is. I haven't seen that kind of a problem with double perclose.
Complication of that, so the angioceal actually embolize.
Pokes in, yeah. If the residual hole is too big, but you should be able to see that with the anchors, right? If the anchors are really holding when pulling back the angioceal, but I guess it's a potential complication. So what are some other alternate large vessel access that you can do and when transfemoral is not enough? Though increasingly it is getting enough. Well, we already heard by some great talks yesterday that direct aortic and transapical, while they were the initial alternate access points for TAVR, are not really used so much anymore because of the increased mortality and worse outcomes. Transeptal is still clearly used for a lot of TMVR type of things. Subclavian access, either direct access or through a graft, can be used. We heard about transcaval. And so I'm going to just talk about a few of these. So axillary, subclavian. You know, axillary subclavian, I think Jamie McCabe, who's from Seattle, has published a series of about 120 patients where they've done access for TAVR through a subclavian approach. Percutaneous. Percutaneous, though he does, okay, I shouldn't say, he does a little cut down himself as the interventional cardiologist, and then just from an EP kind of equivalent perspective, and then does access and does double per close to close. I think it can be done safely. I'll say that in our institution, we haven't done a non-surgical cut down subclavian TAVR, but I have put in balloon pumps percutaneously, and you can do it actually. There was a patient who was in shock who we wanted to put in was balloon pump dependent, was going for LVAD, wanted him walking to get more rehab before he gets to the VAD. So we put in, and his creatinine was 4. So we went into the subclavian artery, used a wire access through the radial to guide us fluoroscopically, poked in it using landmarks, got access, and then he had a balloon pump the upside down way. And so with the balloon pump, he was able to do a little bit more rehabilitation and walk. Obviously, you can't walk much with a balloon pump in your body, but still, you can do a little bit. And that was the whole idea, was to get him out of bed in approach to his LVAD. And we've been doing more. Our heart failure team seems to really like these subclavian balloon pumps, so they often ask for them in a lot of situations. Okay, the carotid data. So I have not done carotid access for any intervention. I know pediatrics often does it. Who here has carotid experience? Oh my God, so all the pediatric guys essentially. Any comments on that?
So I did my fellow in the lab with Chris Pettit.
Yeah.
So the way that I think Kenny does the same way. So you start flipping our patients on the table so that they're kind of working on head towards you,
Yeah.
feet towards that, so they help you flip around, and it makes it nice and easy to get into the carotid. You use a really sharp needle because it likes to move.
Mm-hmm.
There's ultrasound and percutaneous.
And it's percutaneous, all.
And this option when you, the presentation around is fantastic, but that limitation, so like,
Yeah, exactly.
so. What was that?
Yeah, yeah. And I mean, we also jump on the side of the table, just kind of where the orientation based off of your CP.
And then on that side, then you have with the left hand.
They just turn the head to the left and you sit the right on the same side of the table.
Yeah, it's just either way. It's like,
I will say.
Turn the head 180 works the best.
Cervical spine is optional in this particular case.
Babies can turn their head 360.
I see. I will say that the data yesterday that was presented about the increased potential stroke risk in this population for TAVR did really concern me. So I do think that given that femoral is more and more possible, I don't love it. Now, the other thing that I have not done is a transcaval access for TAVR.
For the carotid, you have between percutaneous and between cut down results are 10 times better than percutaneous. A lot more injury, a lot more trauma stimulation, a lot data now. So we actually are moved away from it.
You moved away from it.
In what age group? It's neuromuscular even. And we repaired the brain. Versus for face. Stop myocardium.
So the last axis, alternate axis, I'm going to talk about transcable for a second. Again, I personally don't. Who's done transcable axis here? I think we had this question. Yes, you were the only one who raised your hand. I was on the panel at TCT when Ben O'Neill and the Ford group presented this case. I thought it was really instructive. They did a live case of transcable axis that they made it look so freaking easy, where you just take an electrocautery wire, you have a snare in the aorta, you poke through, you put a microcatheter exchange to a stiff wire, put the sheath in, and at the end you put an ADO. Main point being leaving the track. Don't create a complete seal. Just because of the pressure difference that Rob spoke about yesterday, most of that shunt flow will go into the IVC. I think it's ingenious and a very cool thing, but we have not done it. Okay. So to conclude, exemplary management of large bore arterial access is crucial in our congenital and structural space. Use all four: fluoro, ultrasound, micropuncture, angiography. Everyone in the room, peds, adult, doesn't matter where you are, needs to be comfortable with pre-close, with ProGlide. And femoral access still remains king for structural interventions, though clearly we have other vascular options. So thanks very much.